Morning, everyone. My name is Darius Tannen. I'm the director of the Center for Community Health. Really delighted this morning to have a speaker for a faculty position in our center. Sabira Taher is T32 Cardiovascular Disease Epidemiology Research Fellow at Northwestern's School of Medicine and an adjunct clinical professor in the College of Applied Health Sciences at the University of Illinois at Chicago. Her research focuses on equitable implementation and wide-scale dissemination, behavioral interventions adapted for low-income and immigrant populations. Dr. Taher applies principles of implementation science and community-engaged research to identify and address the multidimensional issues that affect food access, dietary patterns, and cardiovascular disease risk factors in diverse populations. In a moment, I'm going to turn it over to Dr. Taher, but I do want to say this is a virtual hybrid event. There are many of you we know online. As you are listening to the talk, please put your questions in the Q&A feature of Zoom. We will be monitoring that, and those questions will then be given to our speaker afterwards. Please do not use the chat, but use the Q&A function. So with that, I'd like to introduce Dr. Taher.
Thank you. Thanks everybody for your time. Thank you, Darius, for the warm welcome. Yes. Uh-oh. We're having some technical difficulties. You can hear, everybody can hear. Wonderful. So I'm going to be presenting today on optimizing implementation science applications and community engaged research. I just want to give you a bit of an overview of the presentation. Let's see, or not. There we go. So I will talk a little bit about my background and the evolution of my research and how I got to where I am today. And I'm going to then discuss my most recent implementation and community engagement research that commenced in the summer of 2019 and up until now. I've listed the 4 studies that I will be talking about today, focused on primary care focused food security screening and referral implementation evaluation, the South Asian Healthy Lifestyle Intervention Implementation Evaluation Study, implementation evaluation of Northwestern Medicine Social Needs Screening and Referral Program, and Food Insecurity in South Asian Immigrant Communities, an exploratory case study. Then I will conclude with my future contributions in research and practice for Northwestern University and beyond. So let's get started. So I want to start with a bit of my background, and I do this by asking the question, what motivates me? Well, my family motivates me, and you can see a picture of most of them in that up on the slide. My parents are from Bangladesh, so I'm a child of immigrants, and there was a specific life event that affected the way that I viewed healthcare and our public health system. When I was a teenager, my dad experienced a heart attack. He survived. However, throughout the process of getting well, he was tasked with following evidence-based guidelines for chronic disease management, much of which we realized didn't really align with our culture and values. For example, the dietary recommendations he was given really did not align with the traditional Indian cuisine that my dad prefers to consume and eat. And so it was a struggle for him to really find a balance between the evidence-based guidelines for cardiovascular disease management and his values, his preferences. And so this is really what started me on my health equity journey. And I really wanted to find ways to integrate cultural competency into healthcare and really engage those communities that we're trying to reach. So this has culminated in a 16-year career in public health practice and research. And I worked in New York City and Chicago, so really urban environments are my jam. You can see on the right-hand side some of the multi-sector stakeholders I've worked with and that I continue to work with. You'll see community schools, you see federally qualified health centers, municipal health departments. And I really work to provide technical assistance and training in community health promotion and clinical care. And I try to utilize strategies to increase effective uptake of healthcare services across diverse populations, especially where use of healthcare resources is quite low. And I really focus on low-income immigrant and minority population, as well as the service providers that are interacting with them on a regular basis. And I really believe it's important to also educate the future of clinicians and public health practitioners. So I'm also engaged in academic teaching and education. As mentioned, Darius mentioned, adjunct clinical professor at UIC, teaching basically graduate nutrition students about community public health, community engagement. And so my research objective essentially is to bridge the research to practice gap for uptake of evidence-based interventions in real-world settings. So many of you may be familiar with this. This is, in talking about the research to practice gap, this biomedical research pipeline is the main point of contention in that, we're working to establish internal validity with efficacy trials in our interventions. Once we establish that, we move on to effectiveness trials. And there we're trying to establish external validity. And hopefully when that's successful, we move on to application in general practice where there are less and less controlled settings. However, blockages typically occur from unaccounted variations in context. And so it just becomes difficult to apply these evidence-based interventions in real-world settings. And when I say context, I'm talking about alignment with the physical setting, provider capacity to implement an intervention, or availability of organizational resources. It can also be on the recipient side or the patient side. My dad is a great example, some of those evidence-based nutrition guidelines. And so this can then become a threat to fidelity. Fidelity is essentially that we have implemented an intervention in the way that it was intended to be implemented. And if there is a lack of a systematic approach that accounts for contextual variables across settings, then those interventions that have shown effectiveness in controlled settings will demonstrate poor outcomes in real world settings. And so it's really important to take context into account when we're developing strategies for implementation and dissemination. So implementation science was developed to improve the quality and effectiveness of health services and interventions across contexts. It's the scientific study of the systematic uptake of EBIs into routine practice, and really identifies contextual factors that impact uptake across multiple levels within an implementation setting. And what the purpose is to really develop generalizable knowledge that can be applied across different contexts and settings. It is grounded in theory and transdisciplinary in nature, really pulling from disciplines that seek to identify the social, structural, and economic barriers to care. There's several research designs that are utilized: qualitative methods, quantitative research designs, mixed methods designs. And data is typically collected from patients or recipients, providers that are implementing the intervention, as well as organizational leaders, and the broader environmental factors. And what I mean when I say that is I'm talking about economic factors within a specific community, possibly health policy that's been pushed at the moment, for example, sugar sweetened beverages, which is something that I worked on, and the taxation of those beverages, how that affected implementation. And so the consolidated framework for implementation research is the most commonly used framework in implementation research. You'll see this throughout this presentation. This is a framework I utilize. And the main constructs are the innovation, which is the intervention itself and the characteristics of that intervention, the inner setting, which is the implementation context and climate, the outer setting I mentioned before, the environmental factors external to the inner setting, individuals, including the recipients, patients, as well as individuals implementing the intervention and the process of implementation. And so Laura Dem-Schroeder is actually a leader in implementation research, and she developed the Consolidated Framework for Implementation Research and has published on it. And recently she updated the themes of this framework, which she's calling CFR 2.0. And the themes really focus on health equity and an increased focus on people through community and stakeholder engagement. And what I really like about this new feature is this conceptual model that she presented, in that these are how the constructs are related. And you can see that the process of implementation is a dynamic, cyclical process. So that process never really ends. You're always assessing, planning, teaming, engaging, doing, reflecting, and evaluating, and you're working with your stakeholders to do that. Lastly, I just want to show you a model for how we assess implementation conditions and outcomes. It's important to assess the both of them. I talked about CFR already. It answers the question of why. Why did implementation fail? Why did it succeed? And then REAIM, which many of you may be familiar with, which is a popular public health framework used for implementation, it stands for reach, effectiveness, maintenance, implementation, and maintenance, right, I already said that, and answers the questions of who, what, where, how, and when. And King et al. Developed this model, this push-pull model, and essentially push is defined as systematic efforts to convince potential adopters of the value of an intervention. So that's what we call dissemination. Pull is defined as pre-existing preferences, needs, or demands that intrinsically motivate potential adopters to change, or diffusion. And so we can use a technique to elicit pull by tailoring dissemination to address the wants, needs, and concerns of decision makers within the organization to motivate change and adoption. And so I'm going to move on to the research studies that I've been working on, really focusing on implementation science applications to increase uptake of evidence-based practices. And I really wanted to enhance acceptability across diverse communities, cultures, and settings through community and stakeholder engagement. So the first study is primary care focused, hold on one second. Control panel, here we go. Primary care focused clinical food security screening and referral intervention study. This study was funded by the Institute of Research on Race and Public Policy at the University of Illinois at Chicago. This was a dissertation award, and this was my dissertation research. So the problem that was identified is that food insecurity is a social determinant of health that is linked to poor diet and difficulty with disease management. In fact, 1 in 8 Americans experience some type of food insecurity in the United States. It typically affects low-income populations. It's an economic condition whereby quality of healthy food is unattainable, whether it's too expensive or individuals don't have a way to get to the grocery store. Maybe they don't own a car, they lack transportation. And so healthcare experts have really promoted the adoption of validated screening tools within primary care practice to identify food insecure individuals and to refer them to federal benefits such as a SNAP program or local food pantries. Yet a lack of standard practices limits the uptake of these screening interventions. So I'm going to try to proceed to the next slide. So the research purpose of this study was to identify implementation processes and outcomes of current initiatives, and to compare intended program activities, implementation themes across different settings, and to develop generalizable recommendations that can guide uptake across different settings, as well as the development of standard practices. So this was a qualitative embedded multiple case study. We used a grounded theory approach. And I used CFR to guide data collection and analysis. This took place in 10 diverse primary care clinics in Chicago and suburban Cook County. And I conducted stakeholder engagement with 19 health system stakeholders, utilizing semi-structured interviews, an iterative data collection and analysis process until data saturation was achieved. And this process occurred over 6 months. And you can see here, I've highlighted some of this text with red. I really did this so that you could see the consistency in my design and methods throughout the presentation. So you'll see similar models presented in subsequent research studies. And so the main product of this study was this conceptual implementation model. And without going through the details of this entire model, I'm going to be focusing on what is circled in red. And essentially that high adaptability and trialability of this implementation process was enhanced by program resources that were generated from community partnerships that were already established with each health system. And so it really, I think, makes a strong case for why community engagement is so important in this process. And so recommendations for practice are really, allow for adaptations with caution. In these instances, because the community partners were different from location to location, the unique implementation context really fostered implementation feasibility. But we have to be cautious because, again, we have to think about fidelity and we can't really push the envelope too far. Really, it requires this ability to be flexible and also to be able to say, okay, let's go back to the drawing board. This didn't work. So how do we do this better the next time? Also, consider how the context can support intervention activities. As I mentioned before, this community climate was so important for this intervention. Some health systems had partnered with the Chicago Food Depository. And so a referral mechanism was not only enrolling people in SNAP benefits, but also sending them to this food truck that was parked right outside the doctor's office. As soon as they got a referral, they could go shopping for free food, free produce specifically. And so that was one specific community partner that this health system had already created and had established and been working with. So I think it's also important to conduct asset mapping and outreach to potential community partners. This aligns with the previous point, but if you don't understand what's going on in the local landscape, how are you going to be able to refer people to resources who live in that community? So really understanding what's going on around you. Consider non-traditional forms of staff support. In this instance, the intervention was adaptable in that clinicians, as we know, are overwhelmed with many responsibilities, especially in primary care practice. And so they were actually tasked with doing the referral piece of the program. Medical assistants did the screening, physicians then did the referral. The physicians didn't have time for that. So social workers stepped in, as did community partners stepped in to do that referral piece of the program. And I'm trying to click down. Yeah, it's just not proceeding. Hold on one second, everybody. I can't even. Oh, there. Let's try it from the current slide. Thank you. Sorry, everyone. And so this research actually garnered some first author publications. and BMC Public Health in 2022, and Journal of General Internal Medicine in 2021. And so I'm moving on to the next study, which is the South Asian Healthy Lifestyle Intervention, SAHELI. And this is the actual implementation evaluation. This study was funded by the NIH, and the PI is Dr. Namrata Kandula. Many of you know her. And when I came on as a T32 postdoc, the role I took on was a lead implementation scientist. And so what I did was I expanded the current work that had been done on implementation research, developing and integrating new models, as well as developing data collection tools, collecting data, analyzing and interpreting the data. And I also was given a team of junior researchers and colleagues to train on this process. So we had a team of implementation scientists. So the background essentially is that people of South Asian origin are from Bangladesh, India, Nepal, Pakistan, and Sri Lanka. And we are the fastest growing ethnic group in the US, estimated at 5.4 million people. We experience a high burden of cardiovascular disease compared with non-Hispanic white communities and other Asian American groups. However, lifestyle interventions that have been demonstrated as evidence-based, such as nutrition, physical activity, stress management programs, are not reaching South Asian populations. And so this intervention was actually designed using principles of community engaged research. You can see all of the academic partners on the left-hand side from the inception of this trial. And really important, it is governed by a stakeholder advisory board, which is made up of representatives from all of these different partners. And so working together, the stakeholder advisory board developed a tailored evidence-based nutrition, physical activity, and stress management intervention for South Asian adults. And it's a 16-week program that includes motivational interviewing, self-monitoring, and group classes, really to increase the social support, self-efficacy, and to motivate health behavior change. And I think what's really important about it is that it integrated the social, cultural, and community factors that influence South Asian cardiovascular health. So study design and methods for the evaluation, implementation evaluation. So this was a qualitative embedded case study. It was using a grounded theory approach, and we used the integrated CFER and REAIM model to guide data collection and analysis. It took place in 3 community organizations in Chicago and suburban Cook County. It utilized semi-structured interviews with health system stakeholders. This included 1 project manager, 3 health educators, and 24 SAHELI participants. We utilized an iterative data collection and analysis process until we reached data saturation. And the implementation evaluation study commenced in summer of 2020, and it's ongoing. The trial actually ends in December 2022. And so we'll be recruiting additional participants who are completing their 16-week program, and we'll talk to them about implementation as well. So the main findings were essentially identifying barriers and facilitators. So for the barriers that participants identified, females said they really, because of the lack of transportation and scheduling conflicts with responsibilities at home, they couldn't participate in the program at the community setting, the community organization. Many women didn't know how to drive and relied on husbands or other male family members to drive them. And women were typically with the social norm for women in this community to stay at home and care for the children. So this really was a barrier to reach for this particular population. Also, the COVID-19 pandemic reduced group cohesion and social support, which is so important to the South Asian community. Classes that were originally designed as in-group, in-person classes were transitioned to virtual classes. And so it reduced the effectiveness of the program. We learned that a cultural norm is that male participants lacked agency for sustained dietary behavior change. Because they were not the main food preparer in the home, they really lacked control for what the entire family was eating. So they were unable to sustain some of the healthy changes they'd made at the beginning of the program. So some of the facilitators that were identified was that organizations were a bridge to the community in the sense that they had already established relationships with the community. And so there was a certain level of trust that was already there. And it really enhanced reach and acceptability. We did have adaptable implementation, as I mentioned, with the COVID-19 pandemic and the transition to virtual classes. But what that did was it allowed the female participants to actually jump online and participate in the program. So that actually enhanced their participation. Established social networks within the community really helped with dissemination of information about the program and recruitment. And so you also learned that the culturally and linguistically congruent intervention characteristics really enhanced effectiveness, really aligned with the target population, and that group classes, group cohesion and social support, as well as information sharing and motivation also enhanced effectiveness. Tracking tools that were incorporated into the program, such as pedometers and clinical assessments, provided immediate feedback, again, which allowed participants to effectively manage their health. And in terms of maintenance, we did identify female participants as critical change agents for sustained dietary health improvements. And so there was a real push to get husbands and wives to come to this program together, participate together. So essentially implications for practice are that, we achieved overall implementation success with our approach, and that a multi-sector approach can address the cultural, social, and structural determinants of cardiovascular health in South Asian populations. And that a balance between flexibility and fidelity is achieved by aligning intervention goals with the mission of each setting and by ensuring that our intervention mirrored the South Asian lived experience. And because this is an ongoing trial, the manuscript is on hold for publication until the trial ends in December. However, I was given an opportunity to present at APHA in 2021 on some of the process evaluation findings. The theme was creating the healthiest nation, strengthening social connectedness. All right, so moving on to the third study, this is implementation evaluation of Northwestern Medicine Social Needs Screening and Referral Program. This was funded by Northwestern University's Department of Preventative Medicine's Mission Advancement Award. I was a co-PI along with Dr. Stephen Purcell, many of you probably know him, as well as Dr. Cynthia Barnard and Teresa Pollack, both whom are from Northwestern Medicine and on the quality improvement team. So essentially, background is that social determinants of health, as many of us know, continue to negatively affect patient health, and U.S. health systems have adopted social needs screening and resource referrals based on recommendations from the Institutes of Medicine. So Northwestern Medicine developed a screening and resource referral program as well, and wanted to pilot it in a couple of different clinics in order to see how feasible it would be to expand largely across the system. However, a lack of demonstrated implementation strategies limits dissemination of effective practices across diverse settings. So you can see a theme here, right? So the pilot characteristic, or the characteristics of the pilot intervention were that it was implemented in 12 Northwestern Medicine outpatient clinics. The social needs that were screened for was medical home, medication affordability, transportation, food, housing stability, safety, social isolation, and mental health resources. And the questionnaire was actually emailed to patients prior to their visit, or they could choose to take the questionnaire using a tablet in the waiting room. So responses were populated into the EHR, and again, clinicians, the doctors, were tasked with reviewing that social needs and generating a curated community resource list using the online NowPow platform. So the purpose of the study was, the evaluation study was to evaluate the activation of the EHR integrated social needs screening and referral intervention, and to identify the feasibility of implementation within Northwestern medicine, as well as generalizable implementation recommendations. So the design was a concurrent mixed method study. We used a triangulation design where we collected quantitative and qualitative data, and our qualitative data validated our quantitative results. CFR guided data collection and analysis. The setting was 3 Northwestern medicine primary care clinics in Chicago and suburban Cook County. And we utilized EHR patient data from 12,195 patients, semi-structured interviews with 9 primary care team members, and an iterative data collection analysis process until data saturation was achieved. And this was conducted over 3 months. So our quantitative results told us that 45% of patients screened for a concise list of social needs, and that 22% of those patients screened positive for 1 or more social need. 21% of patients requested assistance from Northwestern medicine, and mental health and a need for a regular doctor were identified most. And I wanted to show you the implementation themes and how I included this table because I wanted to kind of show you how coding and analysis is done in terms of how we're coded into CFR constructs, and is this a barrier? Is this a facilitator? Well, I think the major challenge and I think the interesting finding was that the low number of individuals, 20% of individuals that actually screened positive requested help. And so we thought to ourselves, well, why is that number so low? How do we increase that number? And so we learned that it was a combination of factors. Physician lack of time for implementation. In a sense, physicians perhaps didn't even communicate to patients about social needs. A discussion never commenced because they were dealing with other high priority issues in that patient visit. We also learned that the resource list on NowPal was outdated. And so whatever community resources may exist in the real world, either were not represented on that list, or those that were on the list no longer existed. And this really relates to the next theme, which is a limited connectedness to community social needs services. Again, not understanding what's going on outside the clinic walls is going to really stand as a barrier to really changing patient health outcomes, because you need to know what resources exist. And there was no mechanism for patient follow-up after the referral. So even if a patient was referred to a resource, there was no way of knowing whether or not they used that resource. But the facilitators were that the EHR integration really facilitated coordination with screening and referral. That screening process was adaptable to the clinic context, and unanticipated support from existing professional resources both really facilitated uptake. Again, because physicians didn't have time to do that discussion with patients, social workers stepped in, community liaisons stepped in, and this was different across different settings. We also learned that the iPad tablet mechanism, while it can facilitate integration into EHR, there were a lot of technical difficulties. And so a number of clinics actually just went back to a paper survey, and then they populated the responses themselves into the EHR. So essentially, implications for practice are that, system-wide EHR technology and integrated community resource platforms really help with the coordination of implementation efforts. Clinic level champions can really facilitate implementation, step in when there are any unintended barriers that arise. And future research should really examine patient experiences, because we want to know, are these resources useful? Are you using them? And this, I think, goes also to the added need for clinical community partnerships to understand the landscape in the community and to develop feedback loops so that we know when a patient has accessed a resource. And I had the opportunity to present findings at the Midwest Clinical and Translational Research Meeting this year, and was awarded an early stage investigator award for the work that was done. And I'm moving now on to food insecurity in South Asian communities. It's an exploratory study. It's the last study I'll be talking about. This study was funded and is currently funded by Northwestern University Alliance for Research in Chicagoland Communities, this, Coalition Building Seed Grant Award. The co-PIs are Dr. Namrata Kandula and Margaret Clausen. Dr. Clausen is the superintendent of the Skokie Morton Grove School District 69. And I'm the lead researcher. I guess that's what I'm going to call myself. I did the needs assessment, I conceptualized the study, developed data collection tools, and led a team to engage with stakeholders and coalition building to conduct this research. So a little bit of a background, low-income immigrant households with young children in the US have some of the highest rates of food insecurity. Food insecurity as a root cause of health disparities in US South Asian populations is understudied, even as we know that diet is connected to cardiovascular health. And again, we know South Asians experience a high rate of cardiovascular disease episodes. So this study took place in the Skokie Morton Grove, which is in the Niles Township, a suburb of Chicago. And specifically, the Skokie Morton Grove District 69 is a major partner for us in this study. They serve roughly 1,700 children ages birth to 8th grade across 3 schools. And there's a wide variety of immigrant families that have identified as low income that are part of this community. South Asian families make up to 10% of that population. And D69 uses an evidence-based community schools model to transform schools into neighborhood hubs. Essentially, this is where students and families can access an array of social needs and health services. And it really re-envisions schools, not just as academic centers, but as full service community centers. So the purpose of this exploratory study was really to build on current Northwestern University and D69 research partnerships, and leverage this community schools infrastructure and community networks to develop community capacity through coalition building activities. And in doing that, we wanted to work towards identifying root causes of food insecurity and then develop a long-term intervention research plan that could address some of these root causes. We conducted exploratory research using principles of community engaged research, and we assessed existing food access resources and generated an asset map. And you can see on the right-hand side that this is the South Asian Health and Wellness Coalition that we put together. We met about 5 times this past year and engaged in several different types of activities to assess the problem of food insecurity. We talked about principles of community engaged research and really collaborated on this entire study. So it included D69 South Asian parents, community clinics, as well as food access organizations. We had local food pantry that is utilized in the neighborhood. We had urban garden collectives involved. Again, we had Northwestern researchers, and then South Asian food retail businesses to give us an idea about consumption patterns, cost of food. So really all of these individuals interact with the South Asian community on a regular basis and are serving that population. So it's really important to get their input on this study. So this was a qualitative case study, grounded theory approach, and utilized the United States Department of Agriculture validated food insecurity screening tool. We adapted that for this study. The setting was D69 and the surrounding Skokie Morton Grove community. And the methods were semi-structured interviews with lower income Pakistani and Indian D69 parents from the South Asian Parents Neighborhood Network. This was a group of parents that was established prior to this study. D69 established parent networks for different ethnic populations that they serve in order to understand the needs of their immigrant families and to find ways to meet those needs. So this was an iterative data collection and analysis process over 6 months. And so participants basically identified some barriers and facilitators to food insecurity, but I wanted to also point out that we were able to interview 10 participants until we reached data saturation. We learned that the Urdu language was the main language spoken by this community at home, and that they practiced Islam. And then, as I present the barriers and facilitators, you'll see how these all connect. So we learned that limited English language proficiency was a problem with this community in the sense that it combined with the limited concept of food insecurity in Urdu lexicon, as well as the cultural stigma of using social services, resulted in a lack of awareness about SNAP benefits, if they qualified, how to enroll, and usage of local charitable food services. We also learned that religion is tied to charity. So SNAP is a form of charity. In Islam, it's called zakat, charity. And in that religion, individuals are required to give and or receive a certain type of zakat based on their household wealth. This is not the same as household income, because they see this also to include, a marriage dowry that a woman might bring to the household, or gifts from family and friends. And so what we learned from the participants is that even if their household income qualified them for SNAP, they didn't believe they were allowed to take that form of charity based on the religion and the guidelines of zakat. We also learned that a lack of economic stability resulted in the high cost of traditional ingredients that they like to purchase. And this was a result of limited education and lack of legal immigration status that did not allow them to further their economic opportunities and to get higher skilled and higher paying jobs. And we also learned from participants that women typically were more vulnerable to food insecurity in the household. This is actually something that aligns with the literature. Women tend to put their nutritional needs aside for the rest of their family so that the family can eat. They'll skip meals. They will reduce the amount of food that they eat. And this was the same case for this population. So some of the facilitators we identified was that it was really important for participants to preserve their traditional food ways. This served as a way to preserve cultural identity, essentially in a new country. And as you can see from this picture here, the food is very colorful and is full of grains and whole wheat and lentils, fish and meat. And essentially compared to other low income and food insecure households, this is a very highly nutritional diet. And so it could really preserve and protect health. So it's very important to preserve the traditional food ways in this case. Also, trust in religious institutions. Many, as I mentioned before, many participants felt they didn't want to talk to even family and friends about the need for food, but that they would be open to talking to individuals within their religious institutions. And so we are writing up the manuscript at this point and making recommendations. But what we've all talked about is that the social ecological approach that's integrated into a community schools model could be really effective to address these multidimensional issues around food insecurity. And this would really include providing culturally tailored nutrition education, and also working with stakeholders and community members that speak the Urdu language to come up with constructs and concepts that can be integrated into the language about food insecurity? How do they talk about it? And increase resource access and awareness. And this really folds into the next point, is that really engaging mosques as safe spaces for this community to open up about food insecurity, their food needs, and seeking resources. Also connecting families to resources for higher education, hard skills training, and help with the US citizenship process. And expand local food pantry services to more accessible settings, for example, schools. While transportation was not mentioned as an outright barrier, many of the participants did report that they worried about transportation and how they were going to get to the grocery store and back, because many individuals, many families did not own a vehicle. And so they relied on friends with cars and family members, external family members. They also relied on public transportation, but that stress was there. And in food insecurity literature, that stress and anxiety is a characteristic of food insecurity. So I'm going to move on now to some of the future contributions that I hope to make. I think it's, it's a perfect time to say that, I'm also committed to a culture of community engagement, as a Center for Community Health is, and that I'd like to advance the science of community and stakeholder engaged research at Northwestern University and beyond. And so you'll see here, this is a culture of community engaged research with CCH as a focal point. And these are the main functions of CCH, as many of you know. And so what I see essentially is integrating implementation science applications into the work that CCH does, specifically in consultations with researchers and in SHARP panels. And SHARP stands for those who don't know, Stakeholder Academic Resource Panels. I also see, in terms of education and training, contributing to the annual UCAT's D&I reading course, collaborating with the new Center for Dissemination and Implementation Research that will be led by Dr. Sarah Becker, as well as experts on the Bridges team led by Hendrix Brown, and I work with that team already. And to develop and teach material for MPH students at Northwestern, as well as CCH faculty, staff, and community partners. And then in terms of partnerships and funding, I really think that could really add to sustaining current CCH stakeholder partnerships, as well as build new community academic partnerships and relationships with new research projects. And to also seek new funding mechanisms for D&I research. It's still fairly new. It was a conversation I had with Dr. Becker about a month ago, in that, the NIH does not really explicitly tell us what they're looking for in an RFA that is focused on D&I research. So really understanding what needs to be incorporated and what we need to do to get that funding. And then I'm just going to move on to a research study that I would really like to pursue, and that's just building on the ARC study findings and addressing the root causes of food insecurity, poor diet, and adverse health outcomes in the D69 South Asian immigrant families. The setting would be the D69 community. We would continue with the partnership with Northwestern University, ARC, D69, and we would establish new community partnerships as we start developing interventions. And I'm really looking to apply for a multi-year federal funding. The National Institutes of Minority Health Disparities has an RFA to evaluate the effectiveness of culturally tailored interventions. And really it's influenced by this model right here. You have multiple levels of influence from the individual, interpersonal, community, societal levels, in these different domains. And so this is an example of a socio-ecological approach that we may or may not utilize. Much of what is presented on the slide is what we have discussed with our partners. A lot of the stakeholders brought up some of these ideas. Many of the community members also generated some of these ideas. So essentially, the goal is to improve nutrition and diet quality throughout these levels. And from a sociocultural perspective, reducing the stigma to talk about food insecurity and to seek resources. Also, providing job training and English language classes to expand employment opportunities in immigrant communities. Increase capacity to preserve the cultural identity and foodways, as well as traditional family roles of this community. And eventually, we get down to increasing knowledge, acceptability, and motivation to eat healthy at the individual level. From a physical built environment perspective, really increasing capacity of community organizations to refer food access resources. Right now, most of those referrals are happening in healthcare settings, including SNAP enrollment. And as we've learned, clinicians don't really have time to do that type of work. So how do we train faith-based organizations and food pantries to step in and take on some of that responsibility? We also learned that the D69 school community has these beautiful community gardens that are underused. And so many of the participants in this study really wanted to find a place to grow their own produce and traditional ingredients. Why not utilize those community gardens? And then in the family, sort of the family level, the SNAP enrollment could definitely be done by current D69 family liaisons. I mentioned before the parents networks that reach out to immigrant communities. Each network is headed by a family liaison. And that individual is a trusted resource within the community. So why not ask them, hey, can you assist with some of the SNAP enrollment? What can we do to get people to utilize this resource? And home delivered produce boxes and access to affordable culturally specific food was identified. And essentially at the individual level, we're reducing the financial and structural barriers to healthy food. And this is just a proposed model for intervention planning and feasibility testing. It's very similar. It's similar to what you've already seen at the beginning of this presentation, where CFER and REAIM are integrated. And we're not only evaluating, we're using this to determine an assessment of antecedents that will affect implementation and then test that implementation process. So really, in big picture, and what I see in the future direction of community engaged research, I think that we need to integrate an economic analysis of community engaged intervention research using cost effectiveness studies. We really need to identify what activities are effective and what are the costs of engaging in those activities, especially volunteer time and donated time from community stakeholders. We also need to identify and measure the benefits of interventions that were designed using community engaged approaches versus traditional methods. And we really need to assess, what is it the individuals or the recipients are gaining from this intervention? How do we quantify that? It's not only the health outcomes that we're looking at, but this process of engagement as well. And this fits into the next point, the changes in community health. What is the trickle down effect of that? And so we really need to be able to identify effective approaches and methods of community engagement. And, ultimately the ability to quantify outcomes that demonstrate the value of a community engaged research can help inform healthcare policy that is more inclusive and equitable. And so really final thoughts, I believe that my work reflects the goals of health equity research across CCH and Northwestern University. And I intend to further the culture and science of community engagement and translational research with the integration of implementation science applications across the institution and beyond. So thank you very much for your time. Okay.
I think it's easier if you want to just
Stop sharing.
Stop sharing.
Wait a minute. Oh, here we go. Okay.
Actually,
The Q&A?
yeah. So you can, if you want to read that out loud.
Sure.
That'd be great.
Sure. So Lauren Keenan Devlin asks, thanks for sharing these interesting results. On the whole, with the South Asian Healthy Lifestyle Study, did you find that the shift to virtual sessions improved effectiveness, decreased effectiveness, or had a neutral effect on the effectiveness of the intervention? You mentioned the shift to virtual as both a barrier and a facilitator. Very good question. And in terms of effectiveness of health outcomes, we are still waiting for the trial results to be able to validate what we collected from the trial and improvements in health outcomes with our implementation evaluation. So really all I can speak to is the effectiveness of the process of implementation. I would say that essentially it improved effectiveness in terms of reach. And again, at this point, I can't speak to the effectiveness of the actual trial. But the virtual classes were certainly welcomed in many of the female participants and really increased their participation. Thank you for your question.
There's another question.
Leslie Carnahan asks, thank you for your informative and interesting talk today, Sabira. You mentioned using principles of community engagement in the Sahaley study. Can you talk a little bit more about that process? Really good question. Well, I think I would start with saying that principles of community engagement is a broad process, and it's a dynamic process. We are essentially working with partners and engaging partners in informal and formal ways. I think it really depends on what the end goal is. Are you looking to change policy? Are you looking to change health outcomes? Are you looking to reduce structural barriers to services? And it's a process of building trust with community members, the right community members, individuals you find that stakeholders that are aligned with similar goals and outcomes. And it must be an equitable partnership in research. There's no main leader or researcher. In the work that I do with the D69 community, I've learned so much from them and from that process. And in turn, we've met and talked about the basics of Research 101, and they've folded that into a lot of the work they're doing. And it really is a partnership. I was lucky that relationship had already been established prior to the exploratory study. And so engaging in stakeholder discussions and getting individuals on the same page, that can be a very timely process, but it's absolutely worth it because once you get to implementation, you're able to navigate that research to practice gap because you have input from stakeholders about the design of an intervention, what are the needs that they're trying to meet, and implementation processes. So I hope that answered your question. Thank you.
There was one question. Oh.
Thanks.
Could you share more about your experience working with PIs and how you see that effort be in the future?
Sure. Well, with this,
Sorry, can you repeat?
oh, I'm sorry. Is this the mic?
So your computer.
My computer's a mic. Okay, so the question was, what is my experience working with community PIs and how I see moving forward with that experience in my future work. Well, my experience working, I think is my most recent experience with the D69 community, working with Dr. Margaret Klassen. She's a very busy woman, as many superintendents are, and leaders in community are. And so she essentially supports this study, but she is her method is very hands-off. And I think it really depends on who you're working with. It's what is the style of that community stakeholder, that community leader. She acknowledges that Northwestern researchers are coming in with research expertise and community engaged research. But, you know, we're asking a favor of her to utilize her resources and to come into her school and talk to people. And so there has to be a level of, I think, two-way communication and respect, but also I think balancing the fact that she's not going to be involved in the day-to-day of executing a research study like this, but really needs to be, you know, kept in the loop with, you know, ongoing communication via email or, you know, quarterly meetings. And I think that's a bit of a juggling act in moving forward. And you really, you know, taking that into my future work, it's just learning about people and their work style. I think it really comes down to that, and being very open to proceeding in different mechanisms, in different ways, maybe even in ways you're not familiar with, but that's something your community partner has already established and how they do things. So does that answer your question a little bit? I could go on and on about that, but you're welcome.
With that, we're going to wrap up. Just everyone along to their next meeting. Thank you so much, sir.
Thanks, everyone.